So we're good to go.
Good evening, everyone. Welcome you all to the another session of lung transplant masterclass. So each month we'll be selecting a different topics, and whoever is unique in this field usually have a presentation so that everyone knows more detail about the selective problems and what are the different expertise of the speaker. So today we have Professor Chef Keshavjee. So sir is a director of the Toronto Lung Transplant Program. And I think everybody knows Professor Shaf Keshavjee because he's a person who, more than the director of Thoracic Lung Transplant Program, many of them might have seen his TEDx videos, might have got inspired from different talks in multiple YouTube videos. And more than a surgical director, I think he has multiple innovations in the field of lung transplant, right from the fluid that we use for lung preservations and lung boxes, and now the latest EXVIVO lung perfusion. So sir has a variety of or a different spheres of innovations in the field of lung transplant, and he has got a different he's got many awards, especially in the field of lung transplant from the Canadian Society of Lung Transplant. That is a Lifetime Achievement Award. And if you see his awards, I think is N number. So over to Dr. Chef Keshavjee to share his presentation about the different innovations in the field of lung transplant. Over to you, sir.
Okay, can you see my slides?
Yeah,
yes,
able to see your slide, sir. Yes.
And it's on full screen?
Yes, sir. We can see your screen, sir.
Perfect. So, I will thank you again for the honor of presenting to you, and I'll keep this fairly informal so that we can talk about the different topics that are occurring in lung transplantation. But the title you asked for, New Weapons in Lung Transplantation, I think that the key new weapons that we have enabled in lung transplantation is the ability to store the lung at 10 degrees instead of ice or 4 degrees, and ex vivo lung perfusion, which is normothermic. And so I'll show you a little bit about how this has been implemented in Toronto. I have a number of relationships to disclose. I'm the founding partner of Perfusix Canada and Perfusix USA, which we sold to United Therapeutics. It's called Lung Bioengineering, a center that repairs lungs, and EXVIVO Labs, which I was the founder and chief scientific officer. And we then spun this out to be a company called Treferox Technologies that makes devices to repair lungs, the ex vivo lung. I'll show you the Thorax machine, and I serve as the chief medical officer for that company. We've had many important industry partners and collaborators, and we really could not have done all of this work and development without actually having support from these important partners. So the first successful lung transplant in the world was done in Toronto in 1983. And through the 90s and early 2000s, we increased the number of lung transplants performed by using extended criteria donor lungs. So these were lungs that weren't perfect, that we could take and pull the patient through the intensive care unit and successful lung transplant. And then in the mid-2000s, we kind of plateaued at about 100 transplants a year in our program. With the introduction of ex vivo lung perfusion, we truly increased the number of lung transplants. This is without the number of donors increasing, just the number of lungs used. by 100%, fully doubling the number of lung transplants performed per year in our program. And you can see here that we do over 200 lung transplants a year at Toronto General Hospital. And in blue are the lungs that go straight to transplant. In yellow are the lungs that go through ex vivo lung perfusion before going to lung transplant. And this is probably the most important slide, showing that we now do over 200 lung transplants a year with a 2% operative mortality. And you can see that over the time we've decreased the risk of the operation and increased the number of operations that we provide to people, which really is the ideal state that we should aspire to. More lung transplants with less risk and better results. So when you talk about ex vivo organ perfusion, what do we mean by ex vivo organ perfusion? There are different devices for performing EVLP, lung perfusion in this case, and different models for delivery of care. So when I speak of ex vivo lung perfusion, I'm talking about the Toronto ex vivo lung perfusion system. So the lungs, as you see, are kept in a chamber. They're perfused with an acellular perfusate. And pumped with a pump that's a centrifugal pump that has a very low pressure that backs off with any resistance. And they're pumped at 40% of cardiac output with ventilation at a protective lung ventilation of 7 mils per kilogram at a low PEEP and an FiO2 of 21%. The membrane on the pump is run in a sense backwards. It's swept with a gas which is 86% nitrogen, 8% carbon dioxide, and 6% oxygen. So basically, the perfusate removes oxygen, adds carbon dioxide, and then the lung is ventilated with an ICU ventilator so that you can measure the ability of the lung to add oxygen and remove carbon dioxide or ventilate the lung. And therefore you have a system that supports the lung outside the body. In the bottom right is the thorax machine that we have built that really completely puts all of this together in one device, which is a clip-in cassette that holds the lung on the system there. So we first brought this.
Sorry to interrupt, sir. Sir, can you just make your screen full screen, sir? I think the audience is not able to see your screen, sir.
Oh. It says I'm still sharing it. I'll stop again. Can you see that screen now with the device?
Yes, sir. It's not a full screen, sir.
Just trying to figure out how to fix that now. So now you're seeing it in the let me try that again. Sorry about that.
Sir, it was earlier full screen. So you can go to the previous thing, sir.
Yeah, no, I'm just wondering why it changed. I didn't do any. Let me see if I can. Just give me 1 second here if I can see. Do you have it there now? But it's not.
Yeah, now we are able to see it full screen, but we are seeing the icons above. Yeah, now it's okay.
Now it's good, full screen? Okay, sorry about that. Okay, so now you see it full screen with the Toronto ex vivo system on the screen?
Yeah,
yes.
Now we are able to see it full
screen.
Yes, sir. Yes, sir.
So we brought this clinically in 2008, and we've done 1,021 clinical EVLPs to date In the middle there is Marcelo Sipel, who's my partner, and on the right, John Young, who's also my partner. And both of them did their PhD in the lab to develop ex vivo perfusion, and John did the ex vivo perfusion for gene therapy so that we could bring this clinically. And like I said, we've done over 1,000 cases clinically and almost 200 cases with the new device that you see on the right. I think the future state of organ transplantation will be this, that you retrieve organs, transport them to an organ repair center, and then optimize them and then transport them out to the transplant center so that you can put the organ that's optimized for the patient for the specific patient. And you can see I've added 10 degrees, which has really enabled the CIT1 and the CIT2 in the transplant phase. So we built organ repair centers at TGH. We have 3 in our operating rooms right now. And on the right-hand side of the picture, you can see what the organ repair center looks like with the machine there to support the lung. We published in 2011 showing that we could take lungs that no one would use and with ex vivo perfusion successfully transplant those lungs. And then later, when we'd done several hundred of these, we showed that actually 1,000 that we showed that we could have equivalently good outputs and long-term survival of EVLP lungs versus standard donor lungs. So, you know, extended preservation with ex vivo has really changed the paradigm. So you've got procurement, you've got cold ischemic time 1, which is 10 degrees now, EVLP at normothermia, cold ischemic time 2, and then the lung transplant. So this really has changed how we transplant organs. And, you know, Canada is the largest landmass country in the world now. And we've taken lungs from Vancouver, from LA, from Alaska, and brought them to Toronto successfully. So the indications for ex vivo lung perfusion in our center, and I think anywhere in the world, is when you're not comfortable with proceeding directly to transplant with the lungs. If you're comfortable, you do it based on standard criteria. If you're not comfortable, low PO2, less than 300, significant pulmonary edema, bronchoscopic evidence of aspiration or infection where you're not sure if that's significant or not, poor lobar compliance, logistics, like you just don't have the time to get the ORs ready or get to the OR. Most common indication for retrieval for EVLP in our center is retrieval by a non-TGH surgeon, because, you know, training is so variable out there that you really need to know, you never know what you're going to get in the box. So we check it with EVLP. Uncontrolled DCD donors, that's like dead, cardiac arrest donors, and controlled DCDs with long agonal periods. We wait till over 3 hours or more. Medical assistants in dying or MAID donors, we check those lungs on EVLP because you have very little information. And research trial donors, where we're treating the lungs for EBV or hepatitis C or other things, and application of various treatments that we're introducing to EVLP. The average ischemic time for lungs, particularly in the USA, for example, is 5.8 hours. So John Young looked at our experience of lungs preserved greater than 12 hours versus lungs less than 12 hours. And this was still in the 4-degree era. And you can see that we routinely go above 20 hours, and lungs stored for more than 12 hours did equally well as lungs stored less than 12 hours, both in the short term and the long term. And you can see the 2 mortalities, 90-day mortalities, the red stars, were not at the extremes of ischemic time. So this really allowed us to improve the logistics of transplant. And it allows us to get manpower for the operating room, logistical planning for lung, as well as other organs. And you can see this was in June of 2015, but, you know, we often have, you know, kidney transplant, double lung, kidney, double lung, heart transplant, ex vivo double lung, double lung, liver transplant, and double lung. So I was the surgeon on call, so I could organize all of these so that we could continue to do a lot of transplants. It's also important to know that overnight transplantation, it is associated with lower post-transplant survival. And here, this is a UNO study published from Washington University in St. Louis, showing that lungs performed at nighttime in green do worse in the short and long term than lungs performed in the daytime. And I think that also in terms of attracting people to transplantation as a career, that is a challenge. So we've been doing some work in the lab showing that lungs are preserved better at 10 degrees. And we moved this to a clinical study where we said any lung cross-clamped after 6 p.m. would be kept, transported back to TGH, kept at 10 degrees in a fridge, and then transplanted starting at 6 or 7 a.m. So no more night transplants. And I think we can discuss this, but this will be very important in India, where transport times might end up being very long because of traffic or other transportation delays, that you now have some leeway to preserve the lungs. So these are lungs now. This is the first pilot study that we published in Science Translational Medicine. And you can see the donor X-ray, admission to the ICU, 24, 48, and 72 hours. You can see all of these X-rays. First implanted lung, preservation times range from 9.9 to 14.8 hours. Second implanted lung, 10.9 to 16.5 hours. 0% PGD3 at 72 hours. 0% mortality at 30 days, with a hospital length of stay average at 17 days. So you can see that storage at 10 degrees is very effective. And we showed that it maintains mitochondrial health and preserves mitochondrial oxidative function during lung preservation. And then we subsequently published a paper with Vienna and Madrid looking at extending the preservation time. So we would bring the lung to the hospitals on a standard cooler and then preserve it at 10 degrees for 7 hours. And if you look at the red, first lung total preservation time ranged from 7 to 17 hours, and second lung total preservation time ranged from 8 hours and 51 minutes to 19 hours and 41 minutes. And again, this is just the recipient characteristics and outcomes, but in red again, incidence of PGD3 at 72 hours in the 10-degree cohort was 5.7%, and the match controls 9.3%, and the 30-day survival in the 10-degree group, again, 100% and 96% in the matched controls at the time. So we looked at the long-term outcome, and again, the 10-degree lungs did equally well to lungs that were preserved in the standard way. So 10 degrees has now become our standard for CIT1 and CIT2. And the question is, how far can you push this? You've got the cold period, EVLP, and the cold period, and EVLP at 37 degrees does recharge the lungs for the second period. So Adil Ali, who did his PhD with Marcelo in the lab, did a very interesting study, preserved pig lungs for 6 hours at cold degrees, at 4 degrees, so like basically bring it to Toronto, and then 18 hours at 10, 4 hours EVLP, 20 hours at 10, 4 hours at 37, 20 hours at 10 degrees, and then did a lung transplant. And if you look at this slide, these are lungs that were taken out of the pig 3 days before they were implanted. And then on the right there is the PO2, FiO2 on the right lung, with the right lung clamped. On the transplanted left lung alone, a mean PO2 of 400 millimeters of mercury. So that is remarkable outcome, and it had excellent lung preservation and excellent lung histology after that. So these are our lung transplant fellows. That's the Troferox export. Now, you know, ice changes from liquid to solid at 0 degrees. We have gel packs in these export devices that change from liquid to solid at 10 degrees. So you condition the packs in the freezer, you put them in the travel box there, and you can keep lungs at 10 degrees for 48 hours. So you can really extend preservation, and it's portable. There's no electrics to it other than the GPS monitor and the temperature monitor you see there, but which is run on a small battery. It's basically a cooler that keeps the organ at 10 degrees. So the state of the art in lung preservation in 2024 is lungs are preserved as we have with a low potassium dextran flush. That's Perfidex that was discovered here with aerobic hypothermia because the lungs are inflated with oxygen. A 10-degree cooler is the ideal storage technique for lungs. And with this strategy alone, clinical lung preservation has been safely expended well beyond 12 hours in our multi-center. We now have a multi-center trial, 13 centers worldwide, looking at 10-degree preservation. So lungs, the donor team goes out, and if the lungs are transplantable, they're randomized to 4 degrees or 10 degrees and then transplanted. So hopefully we'll have those results. Preliminary results are being presented at the ESTS next week. Lung transplantation can be scheduled to improve logistics, minimize nighttime surgery, and other system disruptions. And I think you can see, like in India, where you are having troubles with transportation, the ability to have some leeway beyond 12 hours of preservation will allow you to do more transplants safely. And the combination of 10 degrees static preservation and 37 degrees EVLP allows remarkable preservation to the tune of days with the opportunity to repair and engineer organs. So in the last few minutes, I'll just talk about some of the repairs we're doing with perfusion, drugs, energy devices, biological therapies. I've been very interested in gene therapy and stem cell therapy. So what are the models to provide clinical ex vivo lung perfusion? You could either do it yourself with a Thorax machine, or do it yourself in a large center like we are, or use a service provider where somebody does it for you. At TGH, basically the staff surgeon makes the initial telephone assessment. The fellows do the on-site assessment and report on the lung function and procurement to the staff surgeon. And the decision about the use of EVLP is jointly made with the fellow and the surgeon over the phone. The lungs are recovered with an LPD flush, cold static preservation for transport both before and after EVLP. And as I mentioned, we use 10 degrees. EVLP is performed at TGH by the ex vivo organ perfusion specialists. And some of our EVLPs are performed by lung bioengineering if the lungs come to us from the States. We have 6 surgical fellows. It's a big program, as I said, doing over 200 lung transplant. And we have 3 organ perfusion specialists on staff who work also in the lab to help us with some of our research programs. There's a call schedule. Now we have a backup call schedule because sometimes we're doing 2 EVLPs at a time. The nurses set up the table, the perfusion sets up the circuit, but with the Thorax machine, you don't need a perfusionist anymore. With the RT checks the ventilator. Again, with the Thorax machine, you don't need an RT anymore. The X-ray technician takes X-rays at 1 and 3 hours, and we're developing AI algorithms to read the X-rays. And basically, the EVLP specialist can prime the circuit and put the lungs on and get it going, and the nurse just returns for the closing count. So the EVLP specialist reports the parameters to us, like you see here, important delta PO2, 519, 522, 550, and the plateau pressures and dynamic compliance and so on. And then we get images of the lung, a 1 hour and a 3 hour X-ray and a post-EVLP perfusion picture so you can see what the lungs look like. We've built in a Toronto lung score, which gives us the degree of inflammation, IL-6, IL-8, IL-1 beta, and IL-10. So it'll tell you that it's a good lung or not, has low inflammation or not. And as an example, here's a lung here. The lung X-ray looks really good at 3 hours. The differential PO2s, like you can even get vein differentials, you can see are all well over 400. The compliance is good. Static compliance is about 140 to 150. So that lung looks good. But when you look at the lung directly, you can see it doesn't look so good as a transplant surgeon, and you'd be a little worried. This happened to be a 28-year-old guy who drove his motorbike into a truck and had a big facial smash and aspirated a lot of blood. So you'd be worried about transplanting a lung that looks like that, even though it performed well on EVLP. But when you look at the inflammation score, you can see aspirated blood is not a particularly inflammatory stimulus, and those lungs were fine, and we were able to transplant them successfully, and the recipient was extubated within a day of the transplant. So EVLP is playing an increasing role in lung transplantation for sure. It does require a large team, resources, and a significant volume of cases to achieve excellent results. It's not just increased donor availability in our region, because lung transplant rates have doubled in our program while other transplants did not. So EVLP has enabled us to use donor lungs with multiple risk factors to address logistical challenges and safely increase the number of lung transplants we do. So I'll end there, and I'll be happy to take any questions you might have.
Thank you, sir, for the excellent presentation. I would now request our Surgical Director, Dr. Balasubramoniam, sir, to have any questions.
Sir, evening, sir. We are really inspired by a fantastic talk. I mean, the numbers are more than 1,000 EVLP experiences are astounding. We are just about starting out with the EVLP programs here in India. Now, I had a few queries, sir. You were speaking about the Toronto lung score. That is used to measure the inflammatory markers in the lung. So could you elaborate on that? What are the markers you actually look for?
Okay, so first of all, with the Toronto lung score, for years we biopsy every lung before we put it in and after, looking for predictors of outcome. Can you predict if that lung's going to do well, and ultimately predict the relationship with the recipient you put it in? And we looked for markers that would predict the outcome. So if you have a high IL-6 or high IL-8 in your lung, that predicts poor, like higher PGD rates, and also earlier chronic lung allograft dysfunction or CLAD. If you have high IL-1 beta, that's very rare actually, but if you see it, it's a very bad sign where the patient will do very poorly after you transplant those lungs. So we built that into the Toronto lung score, which we have that we can get an answer in 20 minutes. The issue, and we're currently doing a trial to see when you add that Toronto lung score to the regular EVLP results, what do you do? And in our preliminary look, it showed that it increased the chance of the surgeons using lungs. Like that example I showed you, I would not have transplanted a lung that looked like that, even though the function seemed good. But that reassured me. The second thing is it also increased the likelihood of us not transplanting a lung that has a problem. So it increased the precision or accuracy of donor lung selection, and in general, increased the total number of lungs. Now, there is so much information coming off of each lung. We've got, PO2, we've got compliance, we've got pulmonary vascular resistance, we've got IL-6, IL-8, IL-1 beta, we've got lactate, glucose, and so on, sodium, calcium. So what we've done is put all of that into AI algorithms that will, we call it Insight X. We just published on it. And we're building that into the machine so that the machine not only does the EVLP, but it'll tell you that that's a good lung that you should transplant it. So it tells you that that's a good lung, transplant it, and the chance that your patient is off the ventilator by 3 days is 93%. So then you can use lungs with more confidence.
So, sir, you mentioned about the Vedic therapeutics that you can do on the EVLP. So, cou- could you elaborate further on what the future holds? So, what can we do as far as therapeutics?
Yeah, so right now on EVLP, we use antibiotics and steroids to treat the lung, which helps with the inflammation and infection. Lungs are very often infected, so that helps. But I think like if the lung has large pulmonary emboli, then we treat with alteplase to lyse pulmonary emboli and improve the lungs. So we've started doing that. And we're just embarking on a trial, a multi-center trial in North America to look at anti-IL-6. So treat upfront with anti-IL-6 to treat both the innate immunity inflammation of ischemia reperfusion injury and acquired immunity to decrease rejection. So I think more and more you're going to start to see the therapies that we already have on the shelf being used on EVLP lungs. Where I think the field needs to go is to look at, can we gene modify the lungs so that they look more like self, so you don't reject them. And I think that's an exciting way to go in the future.
So, sir, what would be your comments on bioengineered lungs? So we hear about having a basic lung scaffolding and having as implanted there. So you really don't require immunosuppression, and that takes up all your concerns of rejection, infection, and all that. So what would be your comments on bioengineered lungs and how it will come up in the future?
I mean, there's different kinds of bioengineering. So two that we're working on is one is gene therapy, like IL-10 gene therapy, so that you downregulate the immune system in the lung itself. So you make a lung that's basically making its own immunosuppression in the lung without increasing systemic immunosuppression. So that would be systemic immunosuppression sparing, which is very exciting. The other way we're doing it is we take your Tregs, amplify them ex vivo, and then deliver them into the lung on ex vivo perfusion so that you now transplant a lung in a context of self. So that's bioengineering lungs that are allografts that can improve the outcome in the long term. The other thing that you can do is like, can you build a whole new lung, right? So if a lung is so badly damaged, strip all the cells of it so that you have a scaffold, then use stem cells to build a lung, a new lung. And that's truly a bioengineered or regenerated lung. And we and others are working on those. And I think it's still a little far to get a lung that'll work. But, some of the advances, like, the kidney xenotransplant that was done was sort of a gene, and it wasn't a regenerated kidney, it was a gene engineered kidney. So we've started with CRISPR gene editing of the lung, and I think that'll come soon.
So in your EVLP program, what will be your rate of rejection even after you do an EVLP? How many lungs do not work even after EVLP?
Yeah, currently, because we're not doing advanced repairs of the lungs, about 30% of lungs on EVLP don't work out. But then you see that's improved our usage of lungs, because if we put a lung on EVLP, 70% will go to transplant, and the 30% that don't work, you don't find out in the patient. You find out on the machine and you just cancel the transplant. So 70% success rate in our program.
And would you tell us, as you develop your EVLP program, what were the challenges that you faced? I'm sure you had more problems initially than now once you have a settled program. So for institutions who may be looking at to start an EVLP program,
Right.
What would be your advice?
Yeah, I think the really important thing is that with EVLP, it's exciting, but it is complex. And we saw that a lot of people doing it with our technique still were failing. We have a 70% success rate. Some very excellent centers using our technology in the early days had a 20 or 30% success rate. So why, right? So what we did, and that's why we're not the first device on the market, we wanted to make it simple, right? So now it's very simple to do it. In terms of actually performing the EVLP. The next question is the decision making on EVLP, right? To say that is that lung suitable or not? And again, there's a lot of clinical judgment that's required, more than we originally thought. Like most people think you just put a lung on EVLP and it's magic, it's going to get better. It's not. So you need judgment and assessment of all of that data. And that's where our AI algorithms are helping us to improve the precision of the judgment and decision making on EVLP. So those were some of the hurdles. The second thing was we developed EVLP for base at hospital. I don't think you need to be flying big, heavy machines all over the country to do that. So a big enabler has been the 10 degrees centigrade cooler, because basically we can pick up a lung anywhere in North America for sure. I think anywhere in the world. So like basically now you can pick up a lung anywhere in India, and you got like 12, 24 hours to transplant it or to put it on EVLP. So in the early days, when we really pushed it on the CIT1, like it was 12 or 14 hours, we'd say, let's just check it on EVLP, make sure it's okay before we implant it. And it was fine. So now we do like 12, 14, 18 hours on 10 degrees, no problem. If we were happy in the donor OR, we go straight to transplant. If we were not happy and we think we need EVLP, then we add the EVLP. So you saw the criteria for EVLP usage. It's not all lungs. It's really when you have a concern.
Sir, one other doubt from one of our audience is if there is a size mismatch, what would be your take at the recipient site about whether to plan lobectomy or keep an open chest, etc., sir?
So first of all, size matching for transplant really should be done based on the predicted TLC of the donor, based on the height, weight, and sex of the donor, and the actual and the predicted TLC of the recipient. Actual you have from PFTs, and predicted are the same formula, height, weight, and sex. So you can match size very well. Now, in general, you want to match to the predicted size of the recipient. But, if the lung's not perfect, then you can adjust the size. So what we usually do, if it's a little trim, first of all, we rarely leave the chest open, very rare. So like out of 200 transplants a year, maybe 1 or 2 would have a chest open. The chest open is usually severe primary graft dysfunction or some other issue rather than size mismatch error, because size mismatch you can fix. So how do you fix size mismatch? If it's definitely a huge disparity, we do a back table lobectomy. The most common operation we'll do is like a whole left lung and a right lower lobe, or a whole right lung and a left lower lobe or left upper lobe. So 1.5 lungs to fit in like an IPF patient or whatever, because you can oversize one lung, but not oversize both. So we do a low 1.5.
Yes.
Other times you do bilateral lobar transplants, right? And again, we do it on the back table. Now, if it's a minor size mismatch, what I like to do is just implant it and then see if I can't close the chest, do some non-anatomic lung volume reduction, right? So with a stapler line, just like you do in LVR. Now, if it's a very big lung and a small chest, what I do is I do a little lung volume reduction on the lower lobe before putting it in, and then put it in, and then look at the upper lobes and see if you need to trim a little bit more, just so you can be trimming all around the lung. Usually the lung volume reduction is in the pulmonary fibrotic patients, right? Because they have a contracted chest.
Yes.
But again, if someone has a lung volume of 1.5 liters and a predicted of 5, I would be looking at a lung like between 4 and 5. If you look at a lung that's 5.5 or 6 liters, you may have a little trouble, and then you have to consider lung volume reduction. But I think that the anatomical reduction is particularly helpful rather than leaving the chest open, because usually those patients will be extubated quickly. If you keep the chest open, then you keep them sedated and delay things and increase risk of infection and so on.
Okay, sir.
Sir, we have a query from one of our listeners. They want to know what's the longest ischemia time you have gone up to, because you have seen you show on a slide where you store over at 10 degrees, you go on for EVLP for 4 hours, and then again you go on to store at 10 degrees. So what's the longest time you have actually done?
Yeah. We pushed it to over 24 hours. I can't really, like, we've had 2 or 3 cases where we were at 24 to 26 hours total ischemic time. We don't do that on purpose. Like, that's logistically whatever, that the stuff happened and it was. Sometimes, we have a big OR. We do 750 750 total transplants a year, plus the oncology program and heart surgery and vascular and so on. So, there's stuff happening. And sometimes we want to do 3 lung transplants in one day, and they just can't accommodate it. And I think the one where we went over 24 hours was like we were really stuck. They just didn't have room to do it. And one surgeon had to wait for another lung. But the ischemic time of 12 to 18 hours, very common now with the 10 degrees, because honestly, most of the surgeons don't do a transplant at night anymore. Like, basically they say, yep, I'll take the lung, I'll do it in the morning, which is very hard for me to figure out, because I've lived through the era of doing transplants starting at 2 o'clock in the morning, as you probably do.
So another query from my listeners: why do you fix the temperature at 10 degrees? Why not 8? Why not 12? What's the significance of the 10?
That's a very important question. We actually published a paper in 1991 showing that 10 was better than 4, better than 8, better than 15. So 10 is the ideal temperature. But at that time, we didn't know why. Since then, we found that the sodium-potassium ATPase in the cell membranes that prevent cell swelling continues to work at 10 degrees, but doesn't work at 4. Like 4 degrees and 0 degrees really shuts the organ down completely. Some of the useful survival functions, like the sodium-potassium ATPase and mitochondrial function, so energy production and oxidative phosphorylation of mitochondria, are continue to work at 10 degrees. So 10 degrees was better. But what happened is the technology evolved to the point where we had fridges that you could set at 10 degrees. So you saw the first study, we just brought the lungs on ice and then put them at 10 degrees and so on. And then we developed the gel packs. So now we don't use ice at all. No ice for organ preservation, and we transport on a 10-degree cooler. The other thing is an important thing. I know you're using ice still, everybody is. You should never have ice in contact with the organ. Many heart surgeons are used to the concept of throwing ice slush on the heart itself. That's bad for the heart, it's bad for the lungs. So when you flush a lung, you keep it in the bag, You keep the low potassium dextran solution. We usually put a liter or two in the bag. Then we triple bag it and then put that bag in the ice cooler. So you have fluid insulating the organ and not having direct ice in contact with the lung tissue because that damages it. So but the problem is that when you put organs on ice, as you know, it can often go very close to zero. And the longer you wait, the colder it gets. And even on the Paragonix device, the longer you stay on it, it goes down to 0 to 2 degrees. So that's not ideal. You really want 10 degrees. And we're doing more work to look at mitochondrial function and other cell functions at 10 degrees, and also to say how can we improve the function, because now the lung can actually work a little bit at 10 degrees instead of being totally put to sleep.
Vimi, any more questions from your end?
No, sir. I think it's a fabulous to see that the work done in his laboratory medicine and how much it is being translated to on patient, and it's a tremendous work, not only about transplant but the innovations that he has put in with a lot of effort and publishing those details in all the reputed journals. And it's a pleasure having you, sir, for our webinar and telling your stories about how these current technology worked and how we can improve, because we are having a lot of challenges, right from lung box and especially about EVLP and the different scenarios to put in. So it was a pleasure having you, sir, and pleasure having to listen to your talk. And thank you. Thanks a lot, sir.
Well, thank you for having me. If I can just make a couple more comments. I'll be coming to the Indian Society for Heart and Lung Transplant in Ahmedabad later this year, I think in October,
Yes.
right? So
Yes,
I look forward, hopefully I'll meet some of you there. One of the talks I'm going to give is really, the future, like how we're CRISPR editing lungs and building new lungs and that sort of thing, which is where we need to see. I think we will all in our career time say, can you imagine how barbaric they were in 2024? We used to just pick up a lung and put it in somebody else. I think that'll come. But the other more practical things is how to preserve a lung to optimize function, right? And I have a movie of donor lung retrieval, which I'll bring and show, and also how to do EVLP. We can talk about that. And also who should do EVLP, how many centers should do it. It is hard and it is expensive, but there are many hospitals in India that have the capacity to do it and should. And I think that, whether it's centralized or in each hospital, we need to figure that out. The other part is transport. Canada is a very big country. It's 3,500 kilometers from one side to the other. And we routinely go to the other ends of the country to pick up organs and dealt with the geography. India has other issues about time and delays in transport and traffic and so on. So I think what we're doing enables the ability to do transplant better and safer and use more lungs. And the other thing that I've been very interested in that I think will probably have more application in India than in Toronto is drone transport of organs. Because, like honestly, from Toronto Airport to TGH in the middle of the day is 40 minutes. But by drone, it's 7 minutes. Right. So for many organs, it's something where you just take traffic out of the equation, right, to transport an organ. And an organ only weighs about 2 kilograms. So it's easy to transport by drone. And we're working with electric drones and stuff, which I think is good. But, some of the gasoline powered drones can still go way further, than land traffic. So as a proof of concept, I'm sort of saying, well, can I send a drone to pick up the lung 1,000 kilometers from me and bring it back? Right? We can do that now. we have that capability. So I think some of the things will be like which centers in India can afford it, and then which centers will just benefit from the 10-degree preservation is not expensive. It's a mindset change that surgeons and physicians need to understand, that it's safe. And you know, as you said, Vimi, it's very important that we didn't bring anything to clinical practice without first testing it preclinically in lab and in animals, so that we're not just adding risk to it. We're trying to improve the outcomes in transplant. So, you know, I look forward to talking more about these concepts, because I think many are applicable in your country as well.
Sure.
Okay.
Thanks a lot, sir.
You're welcome. Good
Thank
to
you.
see you. Hope I'll see you soon in the fall.
Sure. Thank you. Thank you, sir.